Dear Chairman, fellow colleagues, distinguished guests, my name is Sai-Ying Wang. I'm an anesthesiologist at the Sai-Ying Hospital of Central South University in China. First of all, let me thank Professor Rupert for his warm invitation. Now I would like to make a brief introduction about one of the most important clinical trials. Prophylactic use of ketamine reduces postpartum depression in Chinese women undergoing cesarean section. As we all know, postpartum depression, we call it PPD simply, is a common psychiatric disorder that occurs in the postpartum period. The pathogenesis of postpartum depression has still to be determined, and there is no effective prophylactic treatment for postpartum depression, so more studies should be explored. Ketamine, a non-competitive antagonist of the NMD receptor, has been used for many decades as an anesthetic during the surgery, such as cesarean section, and numerous studies have demonstrated that ketamine produces the antidepressant effect in patients with depressive disorder. So, given the known safety of ketamine, an NMD antagonist in obstetrics, we conduct a clinical trial to determine whether the administration of ketamine can attenuate postpartum depression. Next, I will tell you how we designed and implemented the clinical trial. Our study was conducted in the Sai-Ying Hospital of Central South University. We recruited a total 702 pregnant women who underwent cesarean section with spinal anesthesia between August 2014 and December 2016, and they were all agreed to postoperative intravenous analgesia. We exclude the women with hypertension, significant electrocardiogram abnormality, lack of capacity to consent, and inadequate understanding of Chinese. Drug dependence within 6 months. Finally, a total of 654 patients were included in the study. Participants were randomly assigned to two groups using a random number sequence method, the ketamine group and the control group. At 10 minutes after delivery, ketamine 0.5 mg per kilogram diluted to 10 ml with 0.9% saline was administered in the patient by intravenous injection in the ketamine group, but not in the control group. After operation, for the patient in the ketamine group, subentennial 100 microgram ketamine 160 mg and phenylcitin hydrochloride 0.25 mg in 100 mm saline were given using a patient-controlled intravenous analgesia device. We call it PCIA device. For the patient in the control group, subentennial 100 microgram and phenylcitin hydrochloride 0.25 mg in 100 ml saline were also given using a PCIA device. The parameters of both groups are set to infusion rate to milliliter per hour, bolus dose 2 ml, lockout time 8 minutes. This study had two primary outcome measures, including first, the prevalence of postpartum depression according to the Edinburgh Postnatal Depression Scale. We call it EPDS. Second, the prevalence of postpartum blues at 4 to 6 days postpartum, which is defined as a mild and short-lasting ailment. And if postpartum blues last longer than 2 weeks, then it is classified as neurotic depression, which may need psychosocial treatment or drug therapy. Edinburgh Postnatal Depression Scale (EPDS) has 10 items, and each item is scored on a 4-point scale, scored 0 to 3. A total of EPDS score of 0 to 30 points will calculate. The last question item of the EPDS assesses suicidal ideation. I have to mention that an EPDS score more than 9 scores is defined for antenatal depressive symptom, and postpartum mood disorders. We also take some secondary outcomes into consideration, including the perioperative condition, such as a change of heart rate, oxygen saturation, and blood pressure during operation, intraoperative adverse effects, and postoperative pain levels evaluated by the 11-point numerical rating scale. After operation, the patient was followed up by another trained investigator blinded to the experimental procedure at the hospital at first and second days postpartum and at 4 to 6 days postpartum and 6 to 8 weeks postpartum by telephone. Only the anesthesiologist, who were responsible for ketamine injection and the PCRA device, knew the group assignment, and the participants and other trained investigators were blinded to the group allocation. Demographic and basic information were collected for all participants, including age, body mass index, employment and partner employment condition, artificial impregnation or natural pregnancy, domestic violence, primipara, planned pregnancy, education, pressure during pregnancy, antenatal depressive symptom. After we collected all the data, we used the statistical method to analyze and process them. Finally, we got some interesting results. First, the demographic and clinical characteristics did not differ significantly between the two groups. Second, the prevalence of postpartum depression and postpartum blues in the ketamine group were significantly lower than that in the control group. We can see clearly from the table the EPDS score at postpartum day 4 was significantly lower in the ketamine group compared with the control group. What's more, the prevalence of postpartum blues was significantly lower in the ketamine group, which accounts for 11.9% than that in the control group, 18.3%. Moreover, the postpartum prevalence in the ketamine group was 12.8%, which was significantly lower than that 19.6% in the control group. Third, antenatal and postpartum suicidal ideation levels were not significantly different between the two groups. However, the reduction of suicidal ideation was significantly higher in the ketamine group compared with the control group. Last, logistic analysis shows that the administration of ketamine was a protective factor against postpartum depression. On the contrary, stress during pregnancy, antenatal depressive symptom, and antenatal suicidal ideation were risk factors for postpartum depression. Above is the primary outcomes. We also found some interesting secondary outcomes. At first, the analysis of covariance with repeated measurements showed that there were no significant difference in the change in heart rate, the blood pressure, and oxygen saturation during operation between the two groups. Then adverse events occurred in the ketamine group during operation, including vomiting in 62 patients, dizziness in 18 patients, hallucination in 4 patients, and nystagmus in 11 patients. In addition, the hallucination symptoms in patients were temporary and recovered immediately. No other psychotic symptoms such as paranoia, amnesia, or thought disorders occurred in the ketamine group during the operation. In comparison, adverse events in the control group including vomiting in 30 cases and dizziness in 14 cases. In general, the occurrence of vomiting were significantly less in the control group compared with the ketamine group. No other adverse reaction were observed in the control group. And during PCI time, no obvious adverse reaction were found in both groups. Last, the mean numerical rating scale score in the first and second operation day did not differ significantly between the two groups. As shown in the table, the mean numerical rating scale score in the first and second post-operative day were 1.85 and 1.20 in the ketamine group, respectively, which was comparable to that in the control group, 1.77 and 1.22. Based on the result led to further discussion, the present study investigates the prophylactic antidepressant effect of ketamine in patients undergoing a cesarean section. Ketamine administration results in a significant improvement in postpartum psychiatric disorders, as evaluated by the APDS. Furthermore, ketamine exerts an antidepressive effect in patients with moderate stress level during pregnancy and in those with antenatal depressive symptoms and antenatal suicidal ideation. The NMD receptor antagonist ketamine has been shown to produce repeat antidepressive effects in both the clinical and the clinical studies. In the present study, we found that a subancylic dose of ketamine 0.5 mg per kilogram significantly reduced depressive symptoms in postpartum depression, whereas with a single dose ketamine 0.25 mg per kilogram has been reported to exert no obvious antidepressive effect in postpartum women. Notably, ketamine not only decreased the prevalence of postpartum depression, but also the prevalence of postpartum blues. Thus, our findings support the idea that the ketamine can prevent postpartum psychiatric disorders. How ketamine works in postpartum depression. Although the antidepressive mechanism of ketamine in women has not been explored clearly, according to some hypotheses, ketamine produces the antidepressant effect by blocking the NMD receptor and subsequently activates the mammalian target of rapamycin, mTOR, and inhibits the eukaryotic elongation factor 2, EEF2, signaling pathway. First, the activation of mTOR signaling results in an elevation of synaptic spinal numbers and function in the prefrontal cortex, whereas EF2 phosphorylation can destabilize the translation of brain-derived neurotrophic factor that may influence the neuroplasticity. Furthermore, our study supports a previous work showing that antenatal depression is a risk factor for postpartum depression, and approximately 39% of patients experiencing antenatal depression develop postpartum depression. These findings highlight the overlapping pathogenesis of postpartum depression and antenatal depression. Ketamine is well known to produce strong and rapid antidepressive effects in depressive disorders. Thus, we found that ketamine lowered the incidence of postpartum blues in the first week of the postpartum period, and it was associated with a long-term decrease in mood in postpartum women. These results suggest that ketamine may reduce depressive symptoms in the early postpartum period, which contributes to reducing the postpartum depression risk. In summary, we found that the prophylactic administration of ketamine during the preoperative period was beneficial to the postpartum mood. Ketamine administration was relatively safe since it produced only some transient adverse effects, and no obvious adverse effect was observed during the use of PCIA. The future studies are oriented to determine whether the side effects of ketamine can be prevented by other administration routes. In addition, it's necessary to explore the precise antidepressive mechanism of ketamine in women, in the future. That's all I want to talk. Thank you for your attention.